Welcome back to the deep dive. Today, we are immersing ourselves in, well, what's arguably one of the most challenging areas you'll face, both in practice and, in any high-stakes assessment.
Mm.
We're talking about recognizing and responding to neglect.
And specifically, that idea of cumulative harm in children and, on the other side, self-neglect in adults.
Exactly.
This is such critical territory because it demands, well, immediate and really systematic action. The sources we've looked at today are all focused on the UK professional standards.
The GMC framework, the CARE Act.
Right, and they tell us exactly how we have to respond when we suspect this kind of persistent cumulative harm.
That's the key word, isn't it? Pattern. Because a single missed appointment or, a one-off instance of poor hygiene might be worrying.
But it's not the whole story.
Right. The core challenge is seeing that accumulation of small things that, when you put them all together, they cross a critical line.
A threshold.
A threshold that requires a proper statutory intervention. Okay, let's unpack this and give you a really solid, actionable framework.
Yeah, our mission here is to distill the exact mindset you need for safe, lawful practice. We're focusing on decisions that are immediate, proportionate, and, crucially, backed by really robust documentation.
And using the right referral pathways.
Absolutely. Whether that's the MASH, the Multi-Agency Safeguarding Hub for Kids, or kicking off a Section 42 inquiry for an adult at risk, getting those first steps right is, well, it's everything.
Okay, to really set the scene and get a feel for the pressure in these scenarios, let's start with a dilemma. This is a really typical one drawn right from the source material.
Let's do it.
Imagine you're in a busy GP clinic. You see a 3-year-old child. Now, over the last 6 months, your notes show they've repeatedly arrived hungry, unwashed.
Yeah.
You also see they have chronic, untreated eczema and a quick check of the records. They've missed several routine immunizations.
So a few things are already building up.
Exactly. And to top it off, the practice just got a note from the school. Poor attendance, and the child is frequently tired.
Wow. That combination of factors, that should be a huge internal alarm bell going off immediately.
Heavy mix.
A very heavy mix. You've got medical concerns, hygiene, educational risk. It's all there.
So when you're faced with that accumulating evidence of just persistent unmet needs, what are you professionally and legally expected to do? Do you just treat the eczema and send them home?
No, absolutely not. You are expected to move and move quickly from just passive observation to proactive documented action.
Right.
Every single decision you make from that point on has to be grounded in that core principle of protecting the patient and preventing more harm. This isn't a test of your knowledge of eczema.
Yeah.
It's testing your ability to connect those dots and, initiate safeguarding.
So if you had to boil this whole topic down to one single takeaway, what would it be?
The central truth for both child neglect and adult self-neglect is this: spot patterns early, record objectively using a chronology, share information lawfully and minimally, and escalate to the correct statutory safeguarding pathway without any delay.
Okay, and why does this topic matter so much? I mean, beyond the obvious.
Well, this deep dive is so important because neglect causes long-term harm through a kind of persistent failure, not necessarily an acute trauma.
Right.
It hits right at the heart of your core GMC duties. It's about patient safety, and it fundamentally tests your understanding of cumulative harm.
And that's where the SJT assessment can really catch people out, isn't it? Because in real life, when you're swamped, it's so easy to dismiss a missed appointment as just a one-off.
Precisely. Neglect is so easy to miss unless you actually force yourself to document patterns and look at the trajectory over time. The sources are crystal clear on this. The situational judgment test rewards you for building that clear chronology and starting the formal safeguarding process.
And it penalizes you for...
It heavily penalizes you for deciding to just passively watch and wait for some single dramatic crisis.
Yeah.
Your score really hinges on whether you act on that trajectory of decline.
So it's about making a habit of seeing the pattern, not just treating the snapshot. If the only note we have is from today, we just can't see the cumulative harm.
That's right. And your professional principles have to be the anchor for all your actions. The GMC, it provides the scaffolding for every correct decision in these scenarios.
Okay.
We've pulled out 3 foundational principles that are they're non-negotiable.
What's the first one?
First, protect patients and share to prevent harm. This is so key. Disclosing information isn't just allowed, it's necessary when safeguarding is involved.
So that's your lawful basis for sharing.
That's your lawful basis for sharing the minimum necessary data, even if you don't have explicit consent.
Right. And the second?
Second, act on concerns and raise them promptly. Do not, under any circumstances, delay protection. passive monitoring.
Mm.
It just scores so low in these questions because you're postponing that crucial intervention. If you have a concern, act.
Okay, and the third?
And third, keep clear, accurate, timely records. This is your professional anchor. Your documentation has to be strictly objective, comprehensive.
So facts, not opinions.
Exactly. Facts versus opinions, build a proper chronology, and if you can, include verbatim quotes from the patient or the family. That record is what anchors your safe decision-making and justifies why you're escalating.
Okay, this is where the rubber meets the road. We need a practical, step-by-step action plan. So what's the high-yield approach to follow from that first suspicion all the way to a referral?
We rely on a standardized first, next, or last framework. It works for both child and adult scenarios. You just adapt the referral pathway.
Okay, so what's step one?
Step 1. Scan for cumulative patterns. Before you do anything else, you have to mentally or physically turn what looks like an isolated event, like a minor injury, into a timeline.
So review the notes.
Review past notes. Have they missed 6 appointments? Have they been losing weight? This step validates your concern as cumulative neglect, not just a one-off error.
But in a chaotic clinic, finding time to build a clear chronology can be the hardest part, right? How do the sources say we should prioritize documentation when time is so short?
You have to prioritize the facts. Step 2. Record and chronologize objectively. Time pressure is real, I get it. But the record must be objective. Use verbatim quotes like, patient stated they hadn't eaten since yesterday.
Factual.
Completely factual. Avoid judgmental terms like neglectful parent. And if your local policy allows, use tools like body maps or photos to document things, if it's safe to do so.
And step 3.
Step 3. Share information lawfully. This is a critical scoring point. Use secure professional channels, never your personal phone or WhatsApp. Share the absolute minimum necessary information.
And document why you're sharing.
Crucially, document your rationale for sharing without consent. You can and you must share without consent to safeguard a patient.
Okay, then step 4 is the referral itself.
Step 4. Refer and escalate promptly. This has to be timely. For children, you contact the Multi-Agency Safeguarding Hub, or MHH, and you have to figure out the right statutory threshold.
Right.
So if the concern suggests a child in need who requires support, persistent hygiene issues, poor attendance, that's under Section 17 of the Children Act.
And if it's more serious?
If you have reasonable cause to suspect the child is suffering or is likely to suffer significant harm, serious untreated medical issues, repeated malnutrition, that mandates a higher-level child protection inquiry under Section 47.
And what about for adult self-neglect? What's that pathway?
For adults, it goes to adult social care. Here, the key question is whether a Section 42 inquiry under the CARE Act is needed.
Okay.
This is triggered if the adult has care needs, is at risk of abuse or neglect, and is unable to protect themselves because of those needs. But remember, self-neglect doesn't automatically trigger a Section 42, but you must refer if there's a significant risk.
And the final step?
Step 5. Coordinate multi-agency support. Neglect is never solved by one person. You have to liaise with schools, health visitors, housing, maybe even the fire service, especially in complex hoarding cases where fire risk is a major, major hazard.
That systematic approach, it gives you real direction when you're under pressure. To help remember these steps, what mnemonics or memory aids do the sources give us? Let's start with a comprehensive one for general safeguarding. It's Neglect CT.
Good one.
The letters guide you through it. N is for notice patterns. E is for evidence, so collect quotes, maps. G is for get help, MASH H, or adult social care.
Okay.
L is lawful share. E is engage with the person or family when it's safe. C is for chronology, build your timeline. And T is for thresholds, knowing your S.13, S.47, or S.42.
That's a fantastic framework. It covers all the procedural bases. And for that specific challenge of adult self-neglect, which often includes hoarding and health avoidance, there's a simpler mnemonic, CHOA. This helps you quickly assess the whole picture of the self-neglect. C for cleanliness, personal or home. H for health untreated illness, DNAs. O for organization, often related to hoarding. R for risk, crucially, fire risk. And E for engagement, their willingness to work with services. Use CHORE to guide your initial objective notes.
Let's apply this to how the SJT logic actually works. The sources really stress that the exam is designed to test your ability to spot that accumulated risk.
Absolutely. The exam test whether you see that accumulated risk demands a swift escalation. And because of that, it ranks actions that include chronology plus referral higher than any passive option.
Right.
So take that classic child neglect scenario. Repeated poor attendance, hunger, untreated medical conditions. The best action, confirmed by all the sources, is always to build chronology and initiate a same-day MSRA referral.
And that's prioritized over just, say, calling the parent later or waiting.
Much higher.
But why is that same-day referral so crucial? Why does that rank so much higher than just monitoring or rebooking the child in a few months?
Because the risk is already high, and it's escalating. If you delay protection, you miss that window to intervene against the cumulative harm. The combined evidence already meets the threshold for concern.
So choosing to monitor would score badly.
Very badly. Because you failed in your professional duty to act promptly on a known escalating risk.
Okay, now let's think about the complex adult self-neglect scenario. An adult living in squalor, hoarding, clear fire risk, and refusing all help.
Yes. Here we have to bring in the principle of making safeguarding personal, or MSP.
Ah, that's a key distinction. So how does MSP change the logic compared to child protection, where intervention is often mandatory regardless of what the child wants?
Well, MSP means the adult's wishes and their capacity have to be weighed first.
Yeah.
But, and this is a big but, not at the expense of ignoring massive public safety risks, like a fire.
So you can't just walk away because they refuse help?
Absolutely not. The first action is still to build your chronology, refer to adult social care for an assessment, and ensure lawful sharing. But the next actions have to consider proportionality. The best ranking choices will always ensure a thorough assessment of capacity is done, and that multi-agency plans, maybe involving the fire service, are put in place. It's about agreed outcomes rather than just coercive removal. That systematic, safety-first approach always outranks just respecting refusal while ignoring catastrophic risk.
The exam is definitely designed to confuse us. It makes those passive, easy options seem appealing. So what are the low-scoring trap answers we absolutely need to watch out for, and why do they score so badly?
Okay, there are 5 critical traps with neglect you just have to recognize and avoid.
What's number 1?
Trap 1, monitor and see what happens.
Yeah.
This is fundamentally unsafe. Choosing this delays protection and ignores the danger of cumulative harm. It's an immediate low score.
Okay, what's next?
Trap 2, wait for parental or patient consent first. If you delay reporting until you get consent, you fail your professional duty. Consent is simply not required when you're sharing info to safeguard someone at risk of serious harm.
That's a huge one.
A huge one. It shows you don't understand the lawful basis for disclosure.
And trap 3.
Trap 3, discuss the case in an informal staff chat or a WhatsApp group. This is a massive governance and confidentiality breach. Low score, it's insecure, it's excessive information sharing, and it's not using the proper channels.
Okay, what about trap 4?
Trap 4, discharge the patient with advice only. This is just completely unsafe and irresponsible. It gets a major scoring penalty because you're not building chronology, not referring, and you're basically abandoning the patient to an ongoing documented risk.
And the last one?
Trap 5, waiting for a single dramatic event before you escalate. This shows a total misunderstanding of what neglect is. Neglect is the pattern. You have to act on the pattern, not wait for a major crisis.
So the golden rule is clear. A systematic approach of chronology, plus lawful sharing, plus timely referral, beats passive, watchful waiting every single time.
Every time.
Let's drill down into the immediate red flags then. The situations where intervention is mandatory right now with 0 delay.
Okay, these are your quick rules for immediate action.
Go for it.
If a pre-mobile infant presents with bruising or injury, urgent pediatric or safeguarding review is mandatory. Bruising in a non-mobile child is one of the highest possible red flags you can get.
Right.
If you see sustained failure to thrive or significant unexplained weight loss, this points to sustained undernutrition or missed health care. It needs immediate investigation, likely a Section 47 inquiry.
Okay, what else?
If you find unsafe living conditions, especially severe hoarding, that includes a clear and present fire risk. You have to address this. It means involving the local fire service alongside an adult social care referral, even if the patient has capacity.
And finally,
if there is sustained care avoidance with rapidly deteriorating conditions. So repeated DNAs for life-saving treatment or a serious untreated illness. This absolutely requires professional intervention and multi-agency coordination to figure out capacity and safety.
we've covered a huge amount of ground on what is, I think we can agree, an incredibly challenging topic. And if you are preparing for a major assessment in this area, you'll find really detailed revision materials covering all of this at passthemsra.com. So to distill everything down, what are the 3 key takeaways?
Okay, the 3 things you must retain are these. First, cumulative harm needs timelines, not snapshots. Always build a chronology from the existing records.
Got it.
Second, Share information minimally and lawfully to protect the patient. Consent is never a required barrier to start safeguarding.
And third.
Third, refer early and appropriately. MSRA SJT for children, that's your section 17 or 47, or adult social care, considering a section 42, for adults.
Perfect. And for a quick final review of everything we've just discussed, here's a summary. Recognize patterns. Avoid single-incident thinking. Record objectively using quotes, chronology, and body maps. Remember, lawful sharing is required for safeguarding duties. Referral is always better than just monitoring. Self-neglect includes hoarding and fire risk. Think CHORE. And know the difference between this OPA's 200 and S.47 thresholds.
To sum it all up, recognizing neglect is about noticing those subtle trajectories, keeping objective records to anchor your decisions, and making sure you Yes, let's clarify. Child neglect. That's the persistent failure to meet a child's basic physical, emotional, or psychological needs, which leads to serious impairment of their health or development.
And
MSRA, the multi-agency safeguarding hub. It's the single central point for all child safeguarding referrals in the UK.
S.47.
The S.47 inquiry, Children Act. This is the legal trigger for child protection inquiries when you suspect significant harm.
And finally, S.42.
S.42 Inquiry Care Act. This is the statutory duty for adult social care to investigate if an adult with care needs is at risk of neglect or abuse and can't protect themselves.
Thank you for joining us for this crucial deep dive. Recognizing and acting on neglect. It really requires balancing that professional duty with legal clarity.
It does.
Given the necessary focus on chronology and cumulative harm, I'll leave you with this final provocative thought. How might developing a personal habit of objective daily journaling improve your ability to spot and act on cumulative harm, not just in an exam, but in your clinical practice tomorrow? We'll see you next time.